Hi everyone. Today we'll be talking about sodium and water disorders. Now I've divided this topic into three separate lectures. Today we'll be talking about the basics of sodium disorders, the things that you have to understand before going into the disorders of hypernatremia and hyponatremia. Now, talking about several key terms that you have to understand before going into sodium disorders. Now, uh, the word mole is actually a constant number of molecules. So, for example, if we say 1 mole of sodium, we actually mean 6.02 times 10 to the power of 23 molecules of sodium. Now, it's also important to note the difference between osmolarity and osmolality. So, first of all, let's understand what an osmole is. Now, an osmole is when you have, for example, 1 mole of sodium chloride and you dissociate it in water. So, what happens is that when you put sodium chloride in water, it will separate into sodium and then chloride. So it dissociates. Now, so once you had 1 mole of NaCl, and now you have two separate osmoles. So basically, 1 mole of NaCl becomes 1 osmole of sodium and 1 osmole of chloride, and the total is 2 osmoles. And so therefore, osmolarity is the number of osmoles. Now remember this osmolarity, there's an R in the number of liters. So it's the number of osmoles per liter of volume of solution, while osmolality is the number of osmoles per kg of solution, per mass of solution. The idea is that there are several solutions that have something called tonicity. Now, when we're talking about more than one solution, for example, let's in the case of the human body, you have cells swimming in there's interstitial fluid and there's intracellular fluid. So because there is a membrane separating the extracellular compartment from the intracellular compartment, there is this concept of tonicity, and the idea behind it is that the more osmolar solution is, the more likely it is to pull water towards it. So for example, if this extracellular solution was very osmolar, having many molecules and substances, so for example like sodium chloride, high in concentration, it is likely that the water from intracellular compartment will move outwards, and this is actually what happens in cases of cells swimming in a hypertonic solution. So it is important to know that the total amount of body water is actually 60% of the body weight in the human body. And this is divided into intracellular fluid and extracellular fluid. The extracellular fluid is then divided into an intravascular compartment, which is inside the vessels, blood vessels, veins, and arteries, and interstitial fluid, which is the fluid that surrounds the cells. And the environment is in a continuous homeostatic equilibrium. So basically, cells usually swim in an environment that is osmotically equilibrium, electrically equilibrium, and also the acid, the number of protons are balanced inside and outside. So it has this balanced environment. And as we talked about, the idea behind tonicity or effective osmolality, it's the same thing, two interchangeable terms. we said that it happens in cases of having more than one solution, so basically two solutions, and there has to be a semi-permeable membrane. So a membrane that allows some molecules to pass and not others. Therefore, the substances that contribute to the highest osmotic pressure are molecules like sodium, potassium, um, bicarbonate, and chloride. And that's why we study sodium, because sodium is one of the most osmotically effective molecules, and that's why any disbalance or imbalance can lead to changes in the cells, either swelling or shrinkage of cells. Now, the sodium concentration in the extracellular fluid is about 140. So this is the extracellular fluid concentration of sodium, while in the intracellular compartment it is 10 milliequivalents per liter. And you can see that it's outside the cell, it's way more than inside the cell. And the reason for this is actually because there are ionic pumps trying to actively transport sodium from inside the cells outside, and trying to make the potassium enter the cells. And this is the reason why we give isotonic fluids. So isotonic fluids have, like normal saline, they have sodium levels close to 140, so I guess it's about 153 milliequivalents or something like that. And so the reason why we give normal saline is that we don't want to drive any fluid shifts. So giving something that's similar to the fluid, to the same concentration of having the same concentration of sodium in the extracellular compartment, will not drive any fluids to move from the intracellular to the extracellular, or drive any shrinkage or swelling of the cells. Now also, an equation that you might want to memorize is the equation for calculating osmolality, and it's actually 2 times the sodium plus glucose by 18. Now, the reason why we multiply the sodium by 2 is because whenever we calculate the sodium and chloride, so once you multiply whatever amount of sodium, there will be the same amount of chloride available. So because sodium and chloride both are effective substances, or osmotically effective substances, we calculate both of them. Glucose is also another osmotically effective substance. Now, in other formulas they put urea, but urea isn't a very osmotically effective substance, so it doesn't drive fluid shifts and cause changes. So therefore, these are the main players in tonicity. This diagram actually demonstrates the different fluid compartments, and as we said that 60% of body fluid of the body percentage is fluids, and 2/3 of this fluid is intracellular, and 1/3 is extracellular, and the extracellular includes the intravascular and the interstitial space. And so what's happening is that there are these sodium-potassium ATPase pumps that continuously pump 3 sodium out and take in 2 potassium, and this is to keep the equilibrium and keep the concentration of sodium 140 in the interstitial space. And you can actually see that cells have aquaporins, and that free water, if you were to give free water in someone's veins, like dextrose 5 water, or just drinking free water, the free water would actually travel instantly from the intravascular to the interstitial space and instantly into the intracellular compartment, while solutes like sodium and potassium, they would actually need active transport to move. And that's why that is the idea behind a semi-permeable membrane, is that that's why sodium is effective, has high tonicity, or effective osmolar substance with effective osmolarity. It's because that it cannot pass instantly through cells. And in conditions where there is hypernatremia, so for example when you have high levels of sodium, what happens is in the extracellular compartment is that the cells start shrinking, and fluids start moving outside from the cells. While if there is hyponatremia, the cells start swelling, and fluids start moving into the cells. Water moves into the cells. So memorize it like this. It's the opposite. Whenever there's hypernatremia, there is cell shrinkage, and whenever there is hyponatremia, there is cell swelling. Now, this diagram explains the idea. So this is your normal fluid compartments. If you were to add only free water, that would cause expansion of both the extracellular fluid compartment and the intracellular fluid, and that's because free water can pass through aquaporins into the intracellular compartment instantly. While this is actually a bit of a problem in conditions like if someone comes with shock and hypotension, and you give them just free water like dextrose 5 water, the ability to raise the blood pressure needs the fluid for it to stay in the intravascular compartment, and therefore if the fluid instantly moves into the intracellular compartment, that means it's not a very good volume expander. So therefore, once you add something like isotonic saline, which has a sodium concentration that's very close to the sodium concentration in the extracellular fluid compartment, what happens is that you will see that there is an expansion only in the extracellular fluid, and that's because the sodium actually because it cannot pass into the intracellular compartment, the fluids stay in the extracellular. So that's why what we mean by it, that sodium produces this tonicity and effective osmolality, keeping the fluids in the extracellular fluid compartment and causing volume expansion. So always, when you have a patient who's in shock, always give isotonic saline first. Now, if you were to add salts, so salt again does the same idea, that it causes expansion in the extracellular fluid compartment, but what happens is that there is a shrinkage of the intracellular compartment, and it's the same idea that because the sodium increases in the extracellular compartment, now the extracellular becomes hypertonic. It has a lot of osmolar substances in the extracellular, so it pulls the fluids from the intracellular, from the lower concentration of solutes to the higher concentration of solutes in the interstitial and extracellular fluid compartment. So that causes shrinkage of the cells. To understand sodium disorders, you must review the renin-angiotensin-aldosterone mechanism. And what happens is that in cases of a low blood pressure, for example, when the blood pressure decreases, or when the sodium and chloride levels decrease in the blood, is what happens is that these are actually sensed in the aortic arch by baroreceptors, or the juxtaglomerular apparatus, which is present in the nephron. They sense the decrease in blood pressure, and also there's something called the macula densa, which actually measures the levels of sodium and chloride in the blood. And whenever these are decreased, what happens is that the sympathetic nervous system response increases, and therefore the kidneys start secreting renin. And renin changes angiotensinogen, which is produced by the liver, into angiotensin 1, and then angiotensin 1, by the aid of an angiotensin converting enzyme, turns into angiotensin 2. Now, the main player in this is angiotensin 2, which causes increased thirst an increased salt appetite. So you'll be drinking more water in order to raise the blood pressure, and also with more salt intake, of course. And also there will be a vasoconstriction of especially efferent arterioles, which then leads to an increased GFR in the kidneys, and the adrenal cortex or the adrenals then secrete aldosterone, which aids in the reabsorption of sodium and water in order to raise the blood pressure. And another player in this whole system is ADH, and ADH is actually, it works in the collecting ducts of nephrons and is responsible for the reabsorption of free water. Okay, so water without sodium, just water itself. And this is a very important role, because then there can be conditions where you have so much high ADH that will lead to reabsorption of so much free water, and that can cause a relative hyponatremia. This is a syndrome called syndrome of inappropriate antidiuretic hormone release, and we'll talk about this later. The silver equation is a very useful equation in order to understand sodium disorders. And it goes like this: the serum sodium equals the total body sodium by the total body water. Now, bear in mind that the total body sodium is a very good representative of the extracellular fluid volume. And so we can't actually measure the total body sodium in a person. But what we can do is that we can clinically assess a patient and see if they have signs of low total body sodium or high total body sodium. And in conditions of high total body sodium, you will find things, signs and symptoms of hypervolemia. And so you might see that the patient has, for example, pulmonary edema, he has high blood pressure, he has ascites, he has pitting edema, those sort of stuff. While in patients with hypo or decreased total body sodium, you would find symptoms of hypovolemia, which are like decreased skin turgor, sunken eyes. You will find that they have decreased blood pressure, and you won't find signs of pitting edema or cerebral or pulmonary edema. And it's also important to note that serum sodium is actually inversely proportional to the total body water. What that means is that if the total body water increases, serum sodium decreases. If the total body water decreases, then serum sodium increases. And that's why we always try, when we're talking about sodium disorders, we want to know what the serum sodium level is, and we can actually then try to think, well, maybe this patient has gained a lot of free water, which then caused him the hyponatremia, or perhaps they lost free water, which causes again hypernatremia, or they can have an increase in, for example, total body sodium, which then causes an increase in serum sodium. So whatever the condition, whatever the case, you can actually try to understand using this equation. This diagram summarizes all of the sodium disorders, and it's organized in a very nice way. So you have in the y-axis the total body water, and total body water affects serum sodium, and it's inversely proportional to it. So whenever total body water increases, serum sodium decreases. Whenever it decreases, serum sodium increases. Total body sodium is also another factor that plays a role, and it affects extracellular fluid compartment, causing hypervolemia or hypovolemia. And so the way it's organized is that you have this part being hypovolemia, this part being hypervolemia, this part being hyponatremia, and this part being hypernatremia. Okay, so first condition is you have a patient who has hypovolemia and dehydration with hypernatremia. So for example, a patient who has diarrhea and he keeps losing salt and water, and because of the continuous loss of salt and water without any water access, so for example, he's a patient with dementia or impaired thirst mechanism, he keeps losing salts, keeps losing free water, and doesn't replace the fluids. So that can cause, and if the total body water that is lost is more than the total body sodium lost, then serum sodium levels will increase. These type of patients you have to treat with normal saline, especially in cases of shock, and to replace the total body water loss, you have to give dextrose 5 water, and you have to calculate the free water deficit. We'll talk about this in a later lecture, how you can use formulas to calculate. Now, if this patient was to actually have water excess, and then they drink a lot of free water, what happens is actually the opposite. They are losing salt and water by the diarrhea, and now they are having free water access. So the total body water this time will actually start increasing, and so because it's inversely proportional to the serum sodium, then hyponatremia starts setting in. So for these patients, you just give isotonic normal saline. So now we've discussed hypovolemic hyponatremia and hypovolemic hypernatremia. Let's discuss about hypervolemic hyponatremia. Now, for this patient, it's a patient who has, for example, congestive heart failure, cirrhosis, or CKD. These patients, because they have inefficient pumping of blood, for example, in cases of cardiac heart failure, hydrostatic pressure starts increasing, interstitial fluid starts accumulating, and effective arterial blood volume starts decreasing. That will actually cause ADH release. And because there's also decreased blood pressure and decreased efficient blood volume flow through the arteries, that also causes increase in the renin-angiotensin-aldosterone system, causing sodium and water retention. So these patients are having a problem with loads of water being kept in their body, lots of salt being reabsorbed, and so therefore the treatment is going to be salt restriction. You're going to give diuretics to get rid of the excess fluids, and you're also going to do water restriction for them. Now, after treating these patients, you might have this patient becoming an inpatient. He's been on several days on diuretics. These patients start losing a lot of free water, and instead of being in a water excess with and having hyponatremia, now they become hypernatremic. And you can understand it here. So serum sodium equals total body sodium, total body water. So total body water starts decreasing and the serum sodium starts increasing. Of course, the total body sodium is already increasing because they are reabsorbing sodium because of the high aldosterone levels. So this is a patient who has cardiac heart failure and is on diuretics. So we've given examples for the hypovolemia with hyponatremia and hypervolemia with hyponatremia. There's also a condition with euvolemia and hyponatremia, which is a syndrome of inappropriate antidiuretic hormone. So these patients have inappropriate levels of high antidiuretic hormone, leading to reabsorption of free water and leading to an increase in total body water and decreased serum sodium. So this is euvolemic. Now, we discussed hypovolemic hypernatremia and hypervolemic hypernatremia. There's also a condition of euvolemic hypernatremia, which is called diabetes insipidus, and these patients lose some amount of free water, leading to a slight increase in serum sodium. And this summarizes all of the possible outcomes. Now, you can also have a patient who gains pure salt, so someone's ingesting salt. Now, there is a toxic dose for salt ingestion. It's very rare to happen, but it can happen. And there are patients who just lose free salts without any water. Now, thank you for listening. This lecture was based on the basics of sodium disorders. Next lecture will be about hyponatremia.